Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Natharua, a clinical pharmacist by training and profession, who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Natharua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 136 of our pharmacotherapy MCQ series, which majors in infectious diseases. The first question reads, JFA, a 76-year-old male patient is rushed to your accident and emergency department from a long-term care center. He has a chief complaint of increasing tremors and shortness of breath. He has a history of past illness significant for increasing confusion, inability to ambulate over the last 72 hours. He has no fever, chills, dysuria, or urinary incontinence. He has a past medical history significant for type 2 diabetes mellitus, hypertension, right-sided cardiovascular accident which occurred in 2012 with residual deficits, Parkinson's disease and heart failure with a preserved ejection fraction. He has no known drug or food allergies. Currently, he takes metformin 500 mg orally twice daily after breakfast and dinner, amlodipine 10 mg once daily, furosemide 40 mg in the morning. He supplements potassium with 40 ml equivalents orally once daily, aspirin 81 mg orally once daily, and carbidopa-levodopa 25 mg 100 mg orally 4 times daily. Diagnostics on admission include a CT scan, brain, urinalysis with culture reflex and a chest X-ray. His urinalysis results include WBC of 10 to 50 cells per HPF considered few. RBC equal to 0 cells per HPF. Epithelial cells, none. Bacteria 2+. Nitrite, negative. Leukocyte esterase, positive. Protein, none. Reflex culture grows 75,000 CFU per milliliter Enterococcus faecalis. So my question to you is, which of the following treatment options would be the most appropriate in JFA's case considering the above results? Would it be A. Antibiotics are not indicated at this time, or B. Nitrofurantoin macrocrystalline 100 mg orally twice daily, or C. Doxycycline 100 mg orally twice daily after food, or would it be D. Amoxicillin 500 mg orally twice daily? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Antibiotics are not indicated at this time. The rationale behind this answer is that although amoxicillin, doxycycline, or nitrofurantoin would be appropriate treatment for a susceptible E. faecalis UTI, the patient denies signs and symptoms of a UTI including urinary incontinence and dysuria, which suggests no sign of infection, and asymptomatic bacteriuria (ASB) due to the presence of bacteria in her urine. Therefore, antibiotics are not indicated at this time. And the next question reads, S.M.N, a 35-year-old, G2T1 para0A0L1, presents to the OB/GYN clinic for her appointment during week 28 of gestation. She has a past medical history significant for hypothyroidism status post-thyroidectomy and polycystic ovary syndrome. She is allergic to amoxicillin. She had a rash the last time it was administered to her. A review of systems ROS is done and S.M.N denies dysuria, urinary frequency, costovertebral angle tenderness, or suprapubic pain. Some of her pertinent vital signs include hemodynamic stability, blood pressure of 140/85 mm of mercury, a heart rate of 85 beats per minute, a respiratory rate of 18 breaths per minute, and an oral temperature of 98.9 degrees Fahrenheit. Currently she takes metformin 500 mg orally twice daily after breakfast and dinner, levothyroxine 75 mcg daily, in the morning, and maternal multivitamin once daily after breakfast. Other investigations done include a fetal evaluation and a urinalysis. Her urinalysis results include a WBC of 50 to 100 cells per HPF, which is considered moderate, and RBC of 10 to 50 cells per HPF. Epithelial cells none, bacteria 2+, nitrite positive, leukocyte esterase positive, protein none. So my question to you is, which of the clinical or laboratory features listed below places S.M.N at an increased risk of complicated UTI? Is it A, current pregnancy, or B, microhematuria, or C, pyuria, or is it D, polycystic ovary syndrome? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is A, current pregnancy. I would like to begin by commenting that pyuria and microhematuria can be found in the urinalysis of patients with or without a urinary tract infection, but do not increase their risk for a complicated UTI. Polycystic ovary syndrome is not associated with an increase in complicated UTI. However, pregnancy does increase the risk of complicated UTI due to anatomical changes and host factors during pregnancy. And the next question reads, which of the regimens listed below would be most appropriate to manage S.M.N's bacteriuria? Would it be A, antibiotics are not indicated at this time, or B, Nitrofurantoin macrocrystalline 100 mg orally twice daily, or C, ciprofloxacin 500 mg orally twice daily after meals, or would it be D, cefadroxil 500 mg orally twice daily? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B, Nitrofurantoin macrocrystalline 100 mg orally twice daily. I would like to comment that nitrofurantoin has clinical experience and is relatively safe in pregnancy. Cefadroxil would not be appropriate due to a past medical history of rash with penicillin because the chance of cross-reactivity is higher with lower generations of cephalosporins and penicillins. Ciprofloxacin would not be appropriate due to pregnancy and concerns about safety and risk to fetus with this medication. No antibiotics is not appropriate due to potential complications patient is at risk for. And the next question reads, S.M.N is empirically treated with antibiotics. She remains asymptomatic during the entire treatment duration. 28 days later she returns to the clinic for a follow-up appointment. She informs the gynecologist about new and worsening urinary frequency and dysuria. A review of systems ROS is done and she denies fevers, costovertebral angle CVA, tenderness, nausea and vomiting. She is hemodynamically stable and her breathing is unlabored. A normal fetal heart rate is observed. Urinalysis with culture has the following results: greater than 100 WBC, implying pyuria, 0 to 10 RBC, nitrite positive, leukocyte esterase positive, and 3+ bacteria. I advise you to carefully scrutinize the table below. Feel free to pause the video at this stage. S.M.N's urine culture grows E. coli with the susceptibilities shown in the table below. So my question to you is, which of the regimens listed below would be most appropriate for S.M.N now? Would it be A, antibiotics are not indicated at this time, or B, co-trimoxazole 1DS tablets orally twice daily, or C, fosfomycin trimethamine 3 grams orally at once, or would it be D, co-amoxiclav 500 mg stroke 125 mg orally twice daily? And the correct answer is C, fosfomycin trimethamine 3 grams orally at once. Co-amoxiclav is incorrect because 1. The patient has a past medical history of beta-lactam allergy and 2. There was resistance to ampicillin sulbactam, a surrogate. Trimethoprim sulfamethoxazole is incorrect because of safety concerns in first trimester of pregnancy that increase risk of neural tube developmental problems, and later on in pregnancy, it poses risk of displacement of bilirubin and kernicterus. Fosfomycin single dose has been evaluated in pregnancy and appropriate because patient does not have pyelonephritis. No treatment is inappropriate because of risk of fetal complications and preterm birth. And the next question reads, 5 days after completing her treatment, S.M.N reports complete resolution of symptoms. She eventually delivers a healthy 3.6 kg male infant at term, during week 40 of gestation. During delivery she received vancomycin 1 gram IV twice daily times 2 doses for Group B Streptococcus prophylaxis. 48 hours after delivery she spiked a fever, with a body temperature of 102.1 degrees Fahrenheit. Her WBC increased from 6 to 14 times 10 power 9 cells per liter. Her gynecologist orders a urinalysis whose results include the following: gross pyuria and bacteriuria. Examination is done and it reveals tachycardia. She has chills, sweats, and flank pain. A non-contrast CT is done and it is significant for perinephric fat stranding and bladder wall thickening, suggestive of pyelonephritis and cystitis in the appropriate clinical context. Due to S.M.N's uroseptic presentation and past culture history, which of the regimens listed below would be the most appropriate to initiate? Would it be A. Ciprofloxacin 400 mg IV over 30 minutes thrice daily, or B. Piperacillin tazobactam 3.375 grams IV over 30 minutes 4 times daily, or C. Cefepime 2 grams IV over 30 minutes twice, or would it be D. Ertapenem 1 gram IV over 30 minutes once daily? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Ertapenem 1 gram IV over 30 minutes once daily. This patient has evidence of pyelonephritis and history of ESBL E. coli in urine, so carbapenems would be an appropriate treatment option at this time. Past E. coli cultures were resistant to ciprofloxacin. Rash to penicillin makes piperacillin tazobactam and cefepime inappropriate treatment options. Cefepime could be utilized if no other treatment options were available. And the next question reads, G.W.M., a 57-year-old male patient presents to your accident and emergency department with a chief complaint of fatigue, malaise, headache, dark foul-smelling urine, symptoms he associates with past UTIs. He has a past medical history significant for C4 stroke, 5 spinal cord injury secondary to gunshot wound, which occurred in 2015, incomplete tetraplegia, chronic sacral ulcer, bilateral ischial wounds, neurogenic bladder requiring suprapubic catheterization, multiple recurrent UTIs. Some of his pertinent vitals at the A and E include a maximum body temperature of 98.9 degrees Fahrenheit, a heart rate of 97 beats per minute, a blood pressure of 120/75 mm of mercury, and a respiratory rate of 18 breaths per minute. Some of his pertinent labs include a WBC of 5 × 10⁹ cells per liter, RBC of 5 × 10⁶ cells per microliter, a platelet count of 117 × 10⁹ cells per liter. G.M.W. is admitted to your general medical ward. The primary physician ordered a bladder ultrasound and suprapubic fluid sample with culture. Urinalysis showed the following results. More than 100 WBCs, implying pyuria. 50 to 100 RBCs per HPF, 3+ bacteria. Leukocyte esterase positive. Past urine cultures grew ESBL producing E. coli and vancomycin resistant enterococcus, VRE. So my question to you is, which of the clinical factors listed below has the highest specificity for UTI in this G.M.W's case? Is it A. dark urine, or B. malaise, or C. malodorous urine, or is it D. pyuria? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. malaise, and I will tell you why. Pyuria, malodor, and discoloration do not have same rule in value as malaise. That makes answer B the best option. And the next question reads, which of the regimens listed below would be the most appropriate empiric therapy for G.M.W.? Would it be A. Nitrofurantoin 100 mg orally twice daily, for 3 days, or B. Piperacillin tazobactam 3.375 grams IV over 30 minutes 4 times daily for 7 days, or C. Phosphomycin trimethamine 3 grams orally every 48 hours for 3 doses. Or would it be D. Ertapenem 1 gram IV once daily for 3 days? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Phosphomycin trimethamine 3 grams orally every 48 hours for 3 doses, and I will clarify the reason why. Phosphomycin is appropriate based on history of ESBL producing Enterobacteriaceae and VRE. Phosphomycin is active against Enterococcus species and ESBL producing Enterobacteriaceae when MIC is reported as susceptible. Longer course and multiple doses of phosphomycin may be necessary for complicated UTI in males and complicated cystitis. Piperacillin tazobactam is not a good option because of ESBL producing E. coli history. Nitrofurantoin is not a good option due to the duration noted. A longer treatment duration may be required. Ertapenem does not have activity against VRE, and the shorter treatment duration specified above may not be appropriate. I would like to advise you to carefully scrutinize the table below before answering this question. You may need to pause the video briefly. G.M.W's urine culture reveals the organisms and susceptibilities shown in the table in this slide. So my question to you is, which of the regimens listed below would be the most appropriate to recommend for G.M.W? Would it be A. Plazomicin 15 mg per kilogram IV once daily, or B. Ceftazidime avibactam 2 grams stroke 0.5 grams IV thrice daily over 2 hours, or C. Meropenem 2 grams IV thrice daily over 3 hours, or would it be D. Ceftolozane tazobactam 1.5 grams IV thrice daily over 1 hour? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Ceftazidime avibactam 2 grams stroke 0.5 grams IV thrice daily over 2 hours. Ceftazidime avibactam is the most appropriate because it is the only agent adequately studied for complicated UTI specifically caused by carbapenem-resistant species. Although there was E. faecalis found in the urine, it most likely is not clinically significant with only 5,000 CFU per milliliter. Plazomicin does not have enough data to imply it will be effective in the treatment of CRE, as studies only enrolled 4 patients with complicated UTIs. It requires additional studies for C. UTIs. Meropenem is not appropriate due to CRE producing infection. Ceftolozane tazobactam is not appropriate because it is not active against CRE, but is active against many ESBL producing Enterobacteriaceae. It would be helpful if the patient was considered to have this species contributing to the infection. And the next question reads, if this clinical case occurred in the USA, which of the following organisms isolated from G.M.W's urine should be reported to the CDC National Healthcare Safety Network (NHSN) for surveillance? Should it be A. both Klebsiella pneumoniae and E. faecalis, or B. both Candida albicans and Pseudomonas aeruginosa, or C. only E. faecalis, or should it be D. only Klebsiella pneumoniae? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is A. both Klebsiella pneumoniae and E. faecalis, and I will clarify the reason why. VRE and Klebsiella pneumoniae resistant to carbapenems should be reported to CDC and NHSN. Pseudomonas aeruginosa and Candida albicans are not of interest for surveillance purposes. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. On behalf of Dr. Nath Arawa, I would like to remind you that we look forward to interacting with you in part 137 of this series.